You were correct regarding the natural history of a staghorn stone. So this is the landmark article that we need to quote whenever it comes to the staghorn stone, published in 1976. Since then, there has been no such article dominating this field of staghorn stones. So this has greatly changed the thought of management, and this article has emphasized on the importance of managing a staghorn stone. Okay, so why? Because the nephrectomy rates of a patient who are conservatively managed was almost one third. So this is very high. The drainage rate, the percutaneous intervention requirement because of infection or pyonephrosis is about again 30%. So, and the mortality rates were also 28% compared to 7%. I know these percentages are quite too much, but this is a landmark study in Staghorn. In your urolithiasis, you'll find some of the percentages in this article in your Staghorn, and some in your when you talk about the sensitivity or specificity of an investigation there. So these are the areas where you are going to find some of the percentages. Okay, the recurrence rate of the staghorn stones are very high. Again, this is quoted from the Tickman et al. So there are three studies in staghorn stone that you have to remember. One is the this Blandy and Singh study published in 1976. Okay, we spoke about the high nephrectomy rates, infection rates, drainage requirement, and mortality rates favoring intervention in a staghorn stone. So this is the article that you have to quote to the patient and the examiner when they're asking you. Okay. The next is when the examiner wants to know why is there any possibility of offering a conservative management. In that case, you have to quote this article by Subramaniam et al. In 2016. This is again a landmark article and published in BJU, and therefore we have to note it. Okay, so they have compared the in all those problems of a staghorn stone in unilateral and bilateral cases. And what they have found that if the patient has a unilateral stone or a unilateral staghorn stone, and if the patient is asymptomatic, those are those patients where after thorough counseling and explaining about the symptoms, you can keep the patient on surveillance. Otherwise, all the patients of staghorn stone had to be managed with an intervention, surgical intervention. Okay, why? Because of the high incidence of UTI. This is for a bilateral, this is for unilateral, 40-80%. Renal deterioration, you find that 40% deterioration is the bilateral, 6% if there is unilateral. Almost end up requiring dialysis 20% in the bilateral group, 6% in the unilateral group. So these are the problems of a staghorn stone that you need to understand and try to bring about this data as much as possible in your discussion on staghorn management. This articles are going to come up. I think all of my colleagues who have got the staghorn stone in their exam, they have been asked about these studies. Okay. So next is you were right about the pathogenesis. It was a urease producing organism. So just remember some of the urease producing organisms are Proteus, Providentia, Klebsiella, and Pseudomonas. Okay. So it's a lot of P. Okay. So Proteus, Providentia, Pseudomonas, if you can remember this much, and Staphylococcus gram positive. So that will be enough if you can remember few organisms, and then we will understand this. Okay. Is it clear so far, Dr. Ziad?
It's clear, Dr. Ankit. Thank you very much.
Now, I am going to come to this concept on how the urease producing organism they produce this staghorn stones. So let us understand the mechanism. So the urease, or as you said, they are going to split the urea into ammonium and carbon dioxide. This ammonia is very toxic. Okay, it's going to cause epithelial damage. It's going to combine with the water and form ammonium ions. Okay, so that is going to make the urine alkaline. Now, what is happening when there is a urothelial damage? There is damage to the renal tubule epithelium. So in that case, the bacterial, the all those urease producing bacteria, they will attach to the epithelium, damaged epithelium, and they will become nidus. Okay, and the next is when the pH becomes alkaline. The first pathogenesis is by ammonia itself. The second is when the ammonium ion is formed that makes the urine alkaline, and that will cause precipitation of magnesium and phosphorus. phosphate, and this together will form the struvite stone. Now, what happened? This is the formation of a struvite stone. Now, the carbon dioxide will react with water, and there will be production of bicarbonate ions. Okay, and this together combined with uh, they release the hydrogen ions, form the carbonates, and the carbonates combine with the calcium and the phosphonate, and they form carbonated calcium phosphonates. And this is the reason the struvite stones are infection stones. They are very soft. Okay, they are not like staghorn hard stones, but since there is a urea splitting organism which also produces carbon dioxide and a carbonated calcium phosphate, that gives the struvite stone, that makes the struvite stone into a staghorn shape, and that is the reason why they are, occupy the entire system. Okay, the struvite stones, why are they formed? There is infection, there is alkaline pH, and there is precipitation. Now, now there is another concept that you need to understand. What is a matrix stone? A matrix stone happens when this infection stone will be tried to act to be acted upon by the patient's defense mechanism. Okay, if the patient's neutrophils act on this, then they are going to release some proteolytic enzymes. They are going to release some other factors which are going to further cause cleavage or breaking of these soft stones. Okay, and that makes a very soft delicate stones known as matrix stones. They're also infection stones when acted upon by the new patient's defense mechanisms, but when they're acted upon by the carbonated phosphates, they become a solid hard staghorn stones.